Good morning friends. After acute inflammation, let's discuss about chronic inflammation and healing. We will see definition, causes of chronic inflammation, morphological features, cells and mediators of chronic inflammation one by one. Let's see the definition. Chronic inflammation is considered to be an inflammation of prolonged duration, that is for weeks or months, in which you will find active inflammation, tissue destruction and attempts at repair are proceeding simultaneously. As you know, in acute inflammation, the onset is early or sudden. In chronic inflammation, it means delayed onset. This is going to be long lived. So after duration, let's see the second point is cells in active inflammation. The main cell in acute inflammation is neutrophil, while lymphocytes and monocytes are the main cells seen in chronic inflammation. So two aspects after duration and cells. The point to be added is associated with healing or repair and tissue destructions. Whatever damage that occur to the body takes initiate to repair the damages. So main hallmark in acute inflammation was increased permeability of vessels. Vascular permeability is increased, while the hallmark in chronic inflammation is tissue destructions and repair. So chronic inflammation occurs following acute inflammation when tissue destruction is extensive or the bacteria survive and persist at the site of acute inflammation. It can be due to recurrent attack of acute inflammation, which is seen in chronic pyelonephritis or chronic cholecystitis. It is due to chronic inflammation starting de novo, which is seen in Mycobacterium tuberculosis, the organism with low pathogenicity. Let's see or discuss the causes of chronic inflammation. First one is a persistent infection by microorganisms like Mycobacterium, viruses, fungus and parasites. These organisms often evoke an immune reaction called delay type hypersensitivity. You will find in immune system mainly four types of hypersensitivity. Type 1 that is immediate hypersensitivity reaction, type 2 that is antibody mediated, type 3 that is immune complex mediated, and type 4 that is cell mediated or delayed type of hypersensitivity reaction. So chronic inflammation is the delayed type of hypersensitivity reaction. Now immune mediated inflammatory diseases caused by excessive and inappropriate activation of the immune system. The example are immune disease, in which this is the condition in which immune reactions develop against the individual's own tissue. It results in chronic tissue and damage and inflammation. The example are rheumatoid arthritis and multiple sclerosis. Unregulated immune responses against infecting agent, that is seen in inflammatory bowel disease. Third one is the immune responses against common environmental substances like in allergic disease, example is bronchial asthma. Prolonged exposure to potentially toxic agents like seen in long silicosis and atherosclerosis. Let's see the basic histopathology in chronic inflammation. You will find the infiltration with mononuclear cells, that is macrophages, lymphocytes, plasma cells because of persistent reaction to injury. You will find tissue destruction because of inflammatory cells, and you will find angiogenesis in fibrosis, that is attempt of healing by connective tissue and replacement of damaged tissue. In this figure, you will find the both example. In below, you can see there is collection of acute inflammatory cells, mainly neutrophils, and the blood vessels are congested. So this is the example of bronchopneumonia, the example of acute inflammation. In above figure on the right side, you can see the collection of chronic inflammatory cells. Destruction of parenchyma of normal alveoli are replaced by space lined by cuboidal epithelium showing arrowhead, and the arrow show the fibrosis, which is replacement by connective tissue. Let's see feature of chronic inflammation. The main features is mononuclear phagocytic system. Okay, let's see the mononuclear cell infiltration. Macrophages, it is prima donna of chronic inflammation. Stem cell monoblasts, monocytes, macrophages. It means when monocytes is seen remains in bone marrow, it is called monoblast. When it comes into the blood, it is monocytes, and when it comes into the tissue, it becomes macrophages, or it is called macrophages. Macrophages might get activated or differentiated. So here you can see Mainly two type of macrophages are there, M1, M2. M1 is classically activated macrophages. So what will activate this macrophage, or what will it secrete? So some mediators are there which activates this M1. Interferon gamma, it activates the macrophages M1, and this M1 secretes, what it secretes, it's interleukin 1, interleukin 12 and interleukin 23, which is cause inflammation, or these are the inflammatory. Now the M2 is activated by interleukin 13 or interleukin 4. It secretes interleukin 10 or TGF beta, which has the property of anti-inflammatory effects. So M2 is anti-inflammatory and M1 is pro-inflammatory. Lifespan of lymphocytes is 2 weeks to 2 years, where the lifespan of macrophages is 1 to 3 days. Now, macrophages may appear at the site of chronic inflammation from chemoattractive factors of macrophages. As we know, local proliferation of macrophages, longer survival macrophages by immobilization. Macrophages center figure of chronic inflammation because of the great number of substances activated macrophages can produce. Some are toxic to cells, some cause influx of other cell type, some cause fibroblast proliferation, collagen deposition, angiogenesis, but some weaponry can also induce considerable tissue destruction when macrophages are inappropriately activated. So tissue destruction is hallmark of chronic inflammation. Now lymphocytes antigen activated lymphocyte produces lymphokinase interferon gamma, which stimulates monocytes macrophages production, which again produces cytokines which activates lymphocytes. Therefore inflammation persists. Here you can see the lymphocytes and macrophages interact in a bidirectional way, and this interaction play an important role in the propagating chronic inflammation. Macrophages display antigen to T cells, expresses membrane molecules called co-stimulators, and produces cytokines interleukin 12 and other that stimulates T cell responses. Activated T lymphocytes produces cytokines which recruit and activate macrophages, promoting more antigen presentation and cytokine secretion. This results in a cycle of cellular reaction that fuel the sustained chronic inflammation. Here you can see the chronic inflammatory cells, that is lymphocytes. Now let's see the plasma cells. Plasma cells produce antibody against persistent antigen in inflammatory sites and alter tissue component. The other cells are mast cells that are allergic type chronic inflammation, IgE mediated cells. Eosinophils are allergic condition and parasitic infections. This is the eosinophil, bilobed. These are the plasma cells, eccentric nucleus, halo around the nucleus. Now let's see about the tissue destruction. It is activated macrophages are responsible for tissue destruction because of some chemical substances produced by them are hazardous to the host itself. Proliferation changes because of tissue destruction. Neovascularization and fibroblastic proliferation is stimulated, resulting in formation of inflammatory granulation tissue. Eventually, healing by fibrosis collagen line takes place. Systemic effects of chronic inflammation. You will find fever, anemia, leukocytosis, increased ESR, and amyloidosis. Now, mainly two types are there of chronic inflammation: chronic non-specific inflammation and chronic specific inflammation, that is granulomatous inflammation. This is the most important question. Granulomatous inflammation is the most important question for your viva, your theory, as well as your practical aspect. Granulomatous inflammation. What is granuloma? The definition: granuloma is circumscribed tiny lesion 1 mm in diameter, composed of collection of modified macrophages, that is epithelioid cells, and rimmed of the periphery by lymphoid cells. So epithelioid cells are not epithelial cells. Epithelial cells which are seen on the skin or on the surface. This is not epithelial cell, this is epithelioid cells. We will see the features later on of epithelioid cells. Composition. Epithelioid cells. It is modified macrophages or histiocytes which are elongated, having vesicular, lightly staining, slipper-shaped nucleus. It is not round, it is slipper-shaped nucleus and pale staining, abundant cytoplasm with hazy outline. Multinuclear giant cell. Multinuclear giant cell is the fusion of adjacent epithelioid cells and may have 20 or more nuclei. Lymphoid cells are lymphocytes and plasma cells. And necrosis. Here you will find the, if you are finding necrosis, it would be caseous necrosis. Fibrosis due to proliferation of fibroblast. Foreign body granulomas form around materials such as toll, suture or other fibers. Do not incite any specific inflammatory or immune response. Epithelial cells and giant cells are opposed to the surface of the foreign body. The foreign material can usually be identified in the center of the granuloma. Immune granulomas are caused by a variety of agents by inducing a cell-mediated immune response when the inciting agent is poorly degradable or particulate. Macrophages engulf foreign protein antigen, processes it and present peptides to antigen-specific T lymphocytes and causing their activation. Classic example of immune granuloma is infection by Mycobacterium tuberculosis. In this disease, the granuloma is referred to as a tubercle. It is characterized by the presence of central caseous necrosis. Please remember, granuloma in tuberculosis characterized by central caseous necrosis. In contrast, caseous necrosis is rare in other granulomatous disease. Mechanism of evolution of the granuloma. How granuloma form? Because of injury, there is failure to digestion of the agent. Due to this, the weak acute inflammatory responses occur. And due to the persistence of injurious agent, T cell mediated immune response is there and poorly digestible agent is persists. There is activation of T cell, monocyte, chemoattractive factor and growth factor. There is recruitment of circulating monocyte and proliferation of tissue macrophages. Now these macrophages are accumulated in the tissue and there is transform of macrophages to the epithelial cells and giant cells, and thus the granuloma forms. Causes of granulomatous inflammation. The causes are bacterial. It could be due to tuberculosis, leprosy, syphilis, granuloma, inguinally, brucellosis, etc. Fungal. It could be due to actinomycosis, blastomycosis and cryptococcus. Parasites, schistosomiasis, miscellaneous sarcoidosis, silicosis, berylliosis, foreign body granuloma. Here you can see the horseshoe giant cell which is seen in tubercular granuloma. A characteristic tubercular athlete magnification, it shows the central caseous necrosis surrounded by epithelial cells and a multinucleated giant cell. Here you can see the granuloma. Now features favoring the formation of granulomas. Presence of poorly digestible irritant. Organism like Mycobacterium tuberculosis, particles of talc, etc. Presence of cell mediated immunity to the irritant, thereby imply role of hypersensitivity. Now let's see the cause and tissue reaction of different diseases of granulomatous inflammation. First one is the tuberculosis. Causative agent is Mycobacterium tuberculosis. You will find the caseating granuloma tubercle, focus of activated macrophages, that is epithelioid cells, rimmed by fibroblasts, lymphocyte, histiocytes. Occasionally Langhans giant cell, which is horseshoe shaped, central necrosis with amorphous granular debris, Acifas bacilli. Please remember Langhans giant cell, which are horseshoe shaped, seen in tuberculosis, and caseous necrosis seen in tuberculosis. Leprosy, causative agent is Mycobacterium leprae. It is Acifas bacilli in macrophages, non-caseating granuloma. Here you will find non-caseating granulomas. In syphilis, causative agent is Trypanosoma pallidum. You will find Goma, which is microscopic to grossly visible lesion, enclosing wall of histiocyte plasma cell infiltrates central cell necrotic without loss of cellular outline. Now, Kett's-Craig disease. This is gram-negative bacilli. It is rounded or stellate granuloma containing central granular debris and recognizable neutrophils, giant cell, uncommon. Sarcoidosis, unknown etiology. You will find non-caseating granuloma with abundant activated macrophages. Crohn's disease. It is inflammatory bowel disease. Causative agent is immune reaction against intestinal bacteria, self-antigen. Occasional non-caseating granulomas in the wall of the intestine with dense chronic inflammatory infiltrate. Now let's see about the healing. It is the body response to injury in the attempt to restore the normal structure and function. Distinct process. There is the difference between regeneration and the repair. Now, regeneration, when healing takes place by proliferation of parenchymal cells, and usually results in complete restoration of original tissue, while repair is when the healing takes place by proliferation of connective tissue element resulting in fibrosis or scarring. In repair, you will find the fibrosis and scarring. In regeneration, scarring is not there. Healing by first intention, primary union. It is clean and uninfected, surgically incised without much loss of cell and tissue. Edges of wound are approximated by surgical sutures. Reepithelialization to close the wound occurs with formation of relatively thin scar. Healing with second intention, secondary union. Open with large tissue defect, at times infected, having extensive loss of cells and tissue. The wound is not approximated by surgical incision but left open. Healing involves more intense inflammatory reaction, the formation of abundant granulation tissue, and the extensive collagen deposition leading to the formation of a scar. Now you can see healing by first intention and healing by second intention. Healing by first intention, in 24 hours you can see the narrow scape, the neutrophils and clots are there. In 3 to 7 days there is mitosis, granulation tissues are there, macrophages, fibroblasts, new capillaries, and in weeks fibrous union is there. In healing by second intention, you will find the scape is more wide, and you will find more granulation tissue and macrophages in 3 to 7 days, and wound contraction is there on the weeks. Formation of blood clot. Wounding causes rapid activation of coagulation pathways which results in formation of blood clot on wound surface. The clot serves to stop bleeding. Dehydration occurs at the external surface of clot, forming a scab that covers the wound. Acute inflammatory response, which is seen in 24 hours. Neutrophils surface at the margin of the incision. The release of proteolytic enzymes that clean out debris and invading bacteria. In 24 to 48 hours, epithelial changes are there. The basal cells of epidermis from both the cut margins start proliferating and migrating towards incisional space in the form of epithelial spurs. The basal cells from the margin continue to divide by fifth multilayered new epidermis is formed, differentiated into superficial and deep layer. Here you can see in 3 to 7 days the granulation tissue and the macrophages are there. Formation of granulation tissue. Fibroblasts and vascular endothelial cells proliferation 24 to 72 hours. The new vessels are leaky, allowing the passage of plasma proteins and fluid into the extravascular spaces. Thus, new granulation tissue is often edematous. Scar formation. Granulation tissue on maturation become pale. Avascular scar composed of spindle-shaped fibroblasts, dense collagen. The specialized structure of skin like hair follicle and sweat glands are not replaced unless their viable residue remain, which may regenerate. By the end of 1 month, the scar is made up of avascular connective tissue devoid of inflammation covered by intact epidermis. Wound contraction. It occurs in large surface wound, mainly in healing by secondary union. Myofibroblasts present in granulation tissue helps in wound contraction. Factors influencing healing are local factors like foreign body, infection, ultraviolet movement, poor blood supply, type, size and location of wound. Systemic infection like uncontrolled diabetes, hematological abnormalities, administration, glucocorticoids, nutrition and age. Complication of wound healing, infection, implantations, cyst, deficient scar formation, incisional hernia, hypertrophic scar, ankyloid, excessive contraction, neoplasia. Here you can see the keloid formation, hypertrophied scar.